everybody. Sorry, I'm on the wrong slide. We are talking about diabetes this week, and chapter 44 is the 4th edition of Darby and Walsh, and chapter 49 is for the 5th edition, depending on which one you're working out of. These are the objectives. So diabetes is a group of disorders characterized by hyperglycemia, which is high level of blood glucose. It's resulting from defects in either insulin production or how insulin works in the body, or it could be a combination of both. Chronic hyperglycemia damages the nerves, that's neuropathy, and eyes, kidneys, heart, blood vessels, and then microangiopathy, it would be like the tiny little vessels. And the dental hygienist plays a key role in managing oral disease in persons with diabetes, and therefore can really impact their metabolic control. And you guys have a really great opportunity to kind of hands-on utilize this information with your patients in clinic, because we have a lot of patients who have diabetes. So this is nice for this information to actually get put into practical use while you're in school. A normal blood glucose reading would be 80 to 120 milligrams per deciliter, I believe, milligrams per deciliter. And you will probably take many blood glucose tests especially during your senior year. So the dental hygienist's role, so we conduct our periodontal risk assessment, we determine the need for co-management, we monitor the pharmacological history for drug interactions with the glucose control, we minimize potential risk for emergencies, we detect undiagnosed and uncontrolled diabetes, and then we'll refer those out to other healthcare professionals. We modify our dental hygiene care plan on the basis of the patient's needs, and we monitor the outcomes of dental hygiene care through our evaluation. So these are all the things that we do that are integral to helping our patients who have diabetes help get their diabetes under control, stay healthy, have good health, oral health, and keep with the regular appointments with their other practitioners too, so that everything can be positive with their oral health and their overall health. Diabetes, so pre-diabetes, approximately 33.9% of U.S. adult population has diagnosed pre-diabetes. And pre-diabetes is also called impaired glucose tolerance and impaired fasting glucose. Those are terms that refer to the metabolic stages somewhere in between normal glucose homeostasis and diabetes. So they're not quite diabetic, but they're not doing so great either. They're hovering in between. And a very large group population has this prediabetes. Prediabetes has no symptoms, and so it is important for us to recognize these risk factors and ask questions, refer patients to be screened if we can tell that perhaps there's things in their lifestyle that could predispose them to diabetes, and encourage our patients to make healthy behavioral changes. Let's see. I think we get into a little bit more into the lifestyle changes, but just in case, things that we can look at on their medical history are, of course, a history of diabetes in the family, their weight, their diet, their typical nutrition, things like that. If they've ever been told that they are at risk for diabetes in the past, we can ask them about having recent checks and things like that. Daily any kind of physical exercise, how much they incorporate physical exercise into their routine, things like that. So type 1 diabetes is a condition characterized by high blood glucose levels caused by a total lack of insulin. So patients that have type 1 diabetes don't make any insulin at all. And this is because some integral organ in their body stopped functioning. So people who develop type 1 diabetes are rarely obese. Oftentimes it's the opposite due to diabetic ketoacidosis. So they have a buildup of acids in the blood. That's the ketoacidosis. Research studies suggest that there's a genetic origin associated with type 1 and type 2 diabetes. So twin studies reveal that if one twin develops type 1 diabetes, then the other twin develops the disease approximately 50% of the time. That's with type 1 diabetes. The origin of type 1 diabetes can also be an environmental factor, an autoimmune, or a viral infection are things that they're looking into to try and understand why type 1 diabetes happens. Typically, it happens in childhood or adolescence, but it could happen at any time during life, but generally it's younger people who start to express that first. Type 2 diabetes, which is the most common form of diabetes, results from a lack of insulin or the body's ability to use insulin effectively. So they may make insulin, but their body just isn't doing the right stuff with it. So type 2 diabetes is preventable. People with type 2 diabetes constitute approximately 90 to 95% of the diabetic population. Of the undiagnosed, the vast majority have type 2. So generally speaking, you wouldn't be undiagnosed with type 1. It's just too severe and you would just be too sick. You could be undiagnosed with type 2, especially if it was the early stages. The risk of developing type 2 diabetes increases with obesity, age, lack of physical activity, a history of gestational diabetes, hypertension, and dyslipidemia, which is abnormal amounts of fats in the blood. So all of those things are things that you can see on the medical history that can kind of say, okay, they're obese and they are hypertensive. They haven't marked diabetes, but have they ever been screened for it? So stuff like that you could inquire to your patient, especially if their oral hygiene is pretty bad and you can tell if they have periodontal disease or not. So all these kind of clues you can start putting together. It's estimated that people have type 2 diabetes for about 10 years before they're clinically diagnosed. That is a long time to have a disease that you don't really even know you have. Let's see, I lost my place. The risk of developing macrovascular or microvascular complications, that would be problems with the large and small blood vessels, is high with type 2 diabetes. Predominantly, again, it's genetically inherited and has no association with an autoimmune or beta cell destruction. So unlike type 1 that they suspect could have something to do with an autoimmune condition, type 2 is a genetic disposition that's predominantly lifestyle triggered. So there might be you might be genetically predisposition to type 2, but if you lead a very healthy lifestyle, you may never develop type 2. But if you're genetically predispositioned and then you have these lifestyle habits that are unhealthy, then you're more guaranteed of having type 2 diabetes. So gestational diabetes, it occurs in about 4% of pregnancies in the U.S., and clinical characteristics include glucose intolerance that has its onset during pregnancy. So high-risk individuals include women with the following conditions. So if they are obese before getting pregnant, previous gestational diabetes, other pregnancies they had it, then they're at high risk for having it again. Strong family history of diabetes in general, they just have it in. And then glucoseuria, which is glucose in the urine. So if anybody who's been pregnant or has had a close family member knows that every time you go to the doctor, they have you get a pee sample, and they're testing for glucose in your urine. and proteins in your urine and things like that. Women with a history of gestational diabetes have a 35 to 60% chance of developing diabetes during the next 10 to 20 years. 6 weeks or more after pregnancy ends, generally speaking, gestational diabetes will go away. So typically after pregnancy is over and your body's difficulty processing insulin and getting all of the things that happen when you're pregnant that cause gestational diabetes in the first place, it tends to reset and go back to normal. Let's see. So if for some reason, though, after 6 to or 10 to 20 weeks, or no, after 6 weeks or more after the pregnancy has ended and the patient's blood glucose is still very high and it doesn't seem like things have gone back to normal, then the doctors usually reclassify them as having either diabetes, just full-on type 2 diabetes, pre-diabetes, or they'll go back to normal glucose regulation once all their numbers get back to normal. Increases risk of gestational diabetes, increases the risk of prenatal morbidity and maternal complications such as cesarean C-section or cesarean section or hypertension. So these are important things for women to know during pregnancy. Okay, sorry for the little hiccup there in the video. Other types of diabetes can be associated with certain conditions and syndromes, such as genetic defects of the beta cells, pancreatic disease, endocrine disease, chemical-induced agents, and genetic syndromes. These you won't see. They account for only a very small percentage. I think it's like 1 to 3% of diabetes in the U.S., so it'll be a very small percentage. Chances are you won't see this nearly as often as a more traditional type 2 diabetes. It's important for you to know Pacific University's clinical guidelines for treating diabetic patients. So this is just cut and pasted right out of our clinic manual. It's important for you to have it handy just so that you can refer to it easily when you're in clinic. Glucose testing on patients reporting diabetes. Glucose testing may be performed as a screening if a patient reports a family history or answers yes to pertinent diabetes-related questions. So they don't have to have diabetes in order for you to do a blood glucose. You can screen them if you have a question. A1C, patients should maintain 7% or less of an A1C with well-controlled diabetes, or 7.5 in elderly patients with well-controlled diabetes. So if they're older and they give you the documentation that says they were 7.5, that's fine. And then if they're probably under 65, then 7 is what we would want to see. Blood glucose limits up to 250 if the patient has a current A1C. So if you have their A1C documented, you take their blood glucose and it's 235, you can still see them as long as their A1C has been documented at 7 or below. If the patient has not been diagnosed with diabetes and the blood glucose is at or above 200, so 199 is the cutoff, then treatment must be delayed and they must be referred to their physician. Any patient with a blood glucose of 300 or higher should be immediately referred to a physician, and all treatment is delayed until their medical clearance is received.